Hello, everyone. Thank you for joining us. We're here and giving a talk with Eastern Primary Mental Health Network. And the topic of presentation is prescribing psychotropics in pregnancy and obtaining informed consent. I'm Dr. Cindy Fan. I'm a perinatal psychiatrist, and the main speaker today is Dr. Martin Snellen, and I'll introduce him shortly after a few housekeeping slides. We might go to the next slide, Martin. So just quickly with the acknowledgement of country, Eastern Melbourne Primary Health Network acknowledges the Wurundjeri people and other peoples of the Kulin Nation on whose unceded lands we work and the community takes place. We pay our respects to the Aboriginal and Torres Strait Islanders, cultures, and to the elders past and present. And we're committed to healing of the country, working towards equity and health outcomes, and ongoing journey of reconciliation. We recognise the value and knowledge and wisdom of people with lived experience, their supporters, and the practitioners who work with them and celebrate their strengths and resilience in facing the challenges associated with recovery. We acknowledge the important contribution that they make in the development and delivery of health and community services in our catchment. Next slide, please. And also just a bit of housekeeping as well about the Zoom webinar. All attendees are muted and the Q&A box can be used to ask questions. So Martin and I would monitor, or mostly I would monitor the questions during the talk, and we'll address the question at the end. If you have questions later on, you can also email the Primary Health Network email address as well to direct questions to us. This session is being recorded and you'll receive a link at the end. Another thing is that at the end of the talk, there will be a link for any feedback as well. So please take some time to give us some feedback as well. Next slide, please. And I'd like to let everyone know as well that Mercy Health is accepting HealthLink e-referrals, and we encourage you to use that. You can have a look at our website, and there is some information on the slide there for you to refer to. So you have a copy of the slide. Martin, next slide, please. And I'd just like to also introduce Dr. Martin Snellen. Thank you for your time. Martin's a very experienced perinatal psychiatrist who I'm very lucky to work with here at Mercy Hospital for Women in Heidelberg. He also worked in private practice for majority of the week as well. So Martin has published very prolifically in academic journals in areas of relationships between schizophrenia, mental state, and mother-infant interaction and function of specialist mother-baby units, postpartum sexuality, and process of obtaining informed consent when prescribing in pregnancy. He also has special interest in management of bipolar disorder in pregnancy and antenatal care and mental illness and the models of psychotherapy in psychiatric mother and baby settings. He's the author of Rekindling Your Relationship After Childbirth, as well as being the co-editor and chapter author of Psychopharmacology and Pregnancy. So Martin, without delay, I'll let you launch into your talk. Thank you so much for your time.
Greetings. Look, thank you for the kind introduction, Cindy. Welcome to everyone. Thank you for giving us the honour of actually turning up on a Monday night at 7 o'clock. And it means a lot that quite a lot of people have registered. And so my thanks go out to everyone for being here. So my talk I'd like to present today is prescribing psychotropics in pregnancy and the whole issue of obtaining informed consent. And this talk comes together from the thoughts of three people, my own, representing the Mercy Hospital for Women, but also Dr. Jeff Thompson, who's also a consultant psychiatrist who is Associate Dean of Professionalism at Monash University, as well as Mr. Neil Murdoch, who's a Queen's Counsel barrister at the Victoria Bar who specialises in litigation. So really, it was the three of us pulled our heads together to come up with this talk. But the people that I haven't actually acknowledged there are the people who have taught me most of what I know, and that is all the people that have given me the honour of treating them over the years. And it's the thousands of people that I've had an opportunity to care for who have taught me really more than anything any textbook has ever been able to teach me. So if we think about patients presenting with a mental health condition in the context of pregnancy, they fall into one of three groups. For some patients, it'll be the first episode of illness in pregnancy. For some patients, it may represent a relapse of a pre-existing illness during pregnancy, or for others, they may have a chronic illness that actually complicates pregnancy. And when we come to thinking about prescribing medications in this context, each group is quite different. The first episode of illness, we can essentially choose whatever we want and choose the medications we think are the safest and most efficacious options in the context of pregnancy. If a patient has a relapse of a pre-existing condition, we're really looking at using something that has worked for that particular patient before as our first line treatment. And if patients have a chronic illness that complicates pregnancy, we really need to just maximize whatever treatment they are actually on. So the first decision you need to make is, if a patient presents, is which group do they actually fall into? And today's, now I've just lost, we'll get rid of that. So today's presentation will consider a scenario in which a pregnant woman is being treated for a mental illness. And this is a complicated scenario in which conflicting rights may exist, where harm may be done to someone, the fetus, who will later assume legal identity when they become born and a child, in which authorization for treatment is actually sought from another person with a separate legal identity, and that's the mother, who herself may also be harmed by either treatment or non-treatment. And this authorization is sought by a third party, which is you or us, the doctor. For some reason, it's not letting me progress. Okay, so doctors before me today, as a minimum, every time, without exception, there needs to be a careful and considered medical assessment. And this is an area in which we do full assessments, not partial assessments. Really make sure that we really give patients time. Once we've made an assessment, we need to discuss this evaluation with our patients to actually say, this is what I think you have, and this is my suggestions for treatment approach. But if a patient and the doctor is not on the same page, then everything we do subsequently really is a waste of time. And so sometimes in my clinic, I have to say to patients, I desire to depolarize you. I know people have said you've had bipolar disorder in the past, but your history is much more consistent with that of, let's say, a complex PTSD or borderline personality disorder. So if I'm going to make a shift in my diagnosis, I need the patient to come along for the ride with me and spend the time to actually make sure that we are both thinking of the same thing rather than being on different pages. It's very, very important that if a patient is on a medication already, is that we make an active, not a passive decision to continue currently prescribed medications. So if they're on something, don't just go, oh, you're on it, whatever, now you're pregnant. No, that's passive. We need to go, okay, you are on this medication. What are the full implications of this in the context of pregnancy and breastfeeding? And we can't all keep that information in our heads. Like I can, because that's what I do, but most doctors don't. And that's where we need to take the time to find the advice. But very, very, very important, beware of the knee-jerk reaction. So often the medical advice is, oh my God, you shouldn't be on that medication. You need to stop it immediately. And that's often, say, for instance, if a patient's on lithium, operating on advice that we were given at medical school 30 years ago. So there's previous advice and there's today's advice, and always make sure that you're up to date. Be clear in your own mind your rationale for prescribing any and all medications in the perinatal context. If there's any diagnostic or therapeutic uncertainty, consider a second opinion, and then ensure that a process of obtaining informed consent is followed. And that's what today's talk is all about, is to say, how do we actually do that? So risks need to be considered. And last century, Cohen said, when we're prescribing medications in pregnancy, we can get caught between a teratogenic hard rock and a clinical hard place. That is, this area is not easy, but it's not as hard as we think it is sometimes. We need to consider the welfare of both the mother and the fetus. But if there are risks, who has the greater right to be protected, the mother or the fetus? That's quite an ethical dilemma sometimes. And what we do every time is offer a risk-benefit analysis, and more in a moment about what that means. And yes, there are clinical guidelines, such as the NICE guidelines, the College of Psychiatry guidelines, Beyond Blue guidelines. But you know what? Very often these guidelines are so restrictive that we need to actually step away from them and make our own decisions. I prefer to call these things principles of practice rather than guidelines, because guidelines seems to claim that they are an absolute authority and that we should never move outside of them. And I'll talk a bit more about that later as well. So what is a risk-benefit analysis? Well, we need to consider, what are the risks to the mother of any treatment that we are offering? What is the risk to the mother of non-treatment? If we do nothing, what are the risks to her? What are the risks to the fetus of treatment? And what are the risks of the fetus of non-treatment? What does the adverse maternal mental health environment actually result in that can place a pregnancy and the fetus actually at risk? But a risk-benefit analysis, we need to remember, applies to a specific patient within a particular mental health scenario. Always treat the patient in front of you. Never treat the generic patient. What I always say to my patients, we need to think about the implications of you being well on treatment and the implications of you potentially being unwell, untreated. We cannot compare you to the woman next door who is not suffering from a mental health condition and not on medication. We need to consider the two versions of you. And this is a really important point, because if things get complicated and, there's any litigation because these complications emerge, we really need to emphasize the point that we can't compare our treatments to the general population. We have to actually compare our treatments to women with a similar condition who go untreated. So every time when we think about risks, for the fetus, we need to think about four main categories. What is the teratogenic risk? Is the risk greater for a birth defect than the 3 to 5% general population risk? Does the medication increase the risk of any obstetric complication, such as miscarriage, increased risk of diabetes of pregnancy, hypertension of pregnancy, prematurity, babies being bigger than they should be, smaller than they should be? Does our treatment complicate the pregnancy at all? But what about for the risk for the neonate in terms of both medication effects, such as sedation at birth, or subsequently any problems with neonatal adaptation? And after that, are there any potential for withdrawal symptoms for the baby? And what are the risks of negative long-term neurodevelopmental or other health outcomes? And this is where it gets tricky because the medications that we use have not been around for 100 years. Can treatment of depression with sertraline lead to early Alzheimer's? We have absolutely no idea because sertraline has only been around for 30 plus years. And so in many ways, we have to admit to our patients that we cannot speak with 100% certainty about anything. All we can do is speak about the information that we currently have. And for many medications, we have a hell of a lot, and for some, we have none at all. And so in the end, it becomes a balancing act, weighing up what are the risks, what are the benefits. But what we need to remember is this balancing act also exists in a context. And that is, we operate in a world where if things go wrong, people will consider activating common laws and litigation laws in order to hold us to account for the prescribing of a medication that has adversely affected the baby. So it's not just obtaining informed consent, but it's about always recognizing how do we prove to others that we were diligent in this process. So this whole idea of informed consent, well, what is it? Well, it's a doctrine that aims to philosophically, ethically, and legally preserve a patient's right to self-determination. This next sentence I'm going to go through a couple of times. It's a process whereby a clinician secures the authorization of their patient to follow a particular course of medical management, having disclosed to the patient the important features and risks of that course, together with the features and risks of any alternative course open to the patient, so that the patient's decision can be regarded as relevantly informed. It's a process. It is not a moment in time. We need to give the information to the patient. We need to give them an opportunity to go away and contemplate that information, return to us, ask any questions that they desire, and then only at that point pull out the prescription pen, unless we're operating urgently in cases of emergency. What we're doing is we are seeking authorization from our patient. We are actually seeking their permission to do something to them and potentially something to their fetus. And we need to disclose. We need to give information. And in the end, we really have to give all of the information that we know and be very open and honest about the information that we don't know in terms of the risks. We must always consider alternatives because there's very rarely just one path forward in treatment, that there are different pathways we can take, but we need to give the one that we suggest and inform our patients as to why that is our preferred option. And the patients need to be relevantly informed, and more about what that means in a moment. But look, history first. We always benefit from knowing history because it helps us understand why we think what we think today and why we behave today. And so the history of informed consent, it's a story of transformation. For a long time, patient inclusion in the decision-making process was considered to be ill-advised. It was considered to get in the way of therapy. Now patient inclusion in the decision-making process is actually mandatory. It began with the beneficence model, basically saying doctors know best, patients know very little, we should have maximal physician discretion because we are the people who have the knowledge and wisdom. But we've moved now to an autonomy model where emphasis is very much placed on equal patient involvement in the decision-making process. What is interesting is that decision-making is now determined by the informed consent doctrine, which is both a philosophical idea as well as a legal idea. But you know what? The history of the concept of informed consent is also the history of the nature of the doctor-patient relationship. And it discloses a shift in the focus of control from one to the other. So really, the way we think about patients and work with patients now is very different to the way that it was a century ago. And it is the doctrine of informed consent that has actually guided us in this direction, which is a good thing, and in the end, actually not that onerous. When we think about the beneficence model, that endured until the middle of last century, and basically it said the Hippocratic tradition was enough. First, do no harm, always make sure that what you do is in the patient's best interests, and never do things because they're in your particular interests over the patient's interests. And doctors were encouraged to have authority over their patients. It was believed that good healthcare came from obedience. And consent to treatment came from the very act of consulting a doctor. If they walk in to see me, they are consenting that I can do whatever I think is best for them. And it was Benjamin Rush and John Gregory who middle of last century actually said that improved medical outcomes actually come from greater patient understanding through sharing in their doctor's wisdom. They didn't go the extra step, though, and say that they should be involved, just that it is recommended. But in the middle of last century, things changed, and the American Medical Association by 1980 changed this ethic, where the whole focus coming out of the emergence of moral theory said patients always have a right to self-determination. And the sad thing is, this all occurred in the context of litigation. The term informed consent first appeared in 1957 in a lawsuit. Us, the medical profession, we did not come up with this model. We did not propose it. We did not forward it. We did not bring it into practice. The legal system did. And now we consider every patient has the right to protect their bodily integrity. It's been asserted that the initial imperative to seek consent for medical treatment that emerged in the early 20th century was a response to lawsuits rather than a moral imperative to respect patient autonomy by doctors. And I think that is actually true. And the real important definition came out of the Canterbury Spence trial, where the definition where it was said by the magistrate or the judge, true consent to what happens to oneself is the informed exercise of a choice. And that entails an opportunity to evaluate knowledgeably all the options that are available. But when we talk about consent, what are we talking about? Consent to what? And a distinction we need to make between consent to enter into a contract for medical treatment, which is separate to consent to the medical treatment in and of itself. An explicit consent is required for contract for medical treatment, but also another one which must emphatically be distinguished from the various separate medical actions that we take. So there's the consent. I consent for you, Martin, to see me and give you advice. That doesn't automatically give me consent to activate any particular treatment plan. That's a separate step. An informed consent is considered to be given when a patient agrees to a proposed treatment based on their participation in the risk-benefit analysis we talked about earlier. And in perinatal psychiatry, a mother acts as an agent that authorises the acceptance of risk on behalf of her unborn. Now, the unborn has varying levels of legal rights across different jurisdictions. For instance, personhood is determined at conception in Ireland traditionally. I'm not sure if that's actually changed recently or not. But personhood, legal identity in Australia occurs at birth, in that a fetus actually has no legal right. So that's where it's very difficult. For instance, if we're treating a patient with anorexia nervosa who's grossly underweight and there's fetal growth restriction, we cannot activate the Mental Health Act to feed mother on behalf of her fetus. We can only enact the Mental Health Act in order to feed her to save her life, not the fetus's life. And in bold, I really emphasize as well, is that patients have the legal and ethical right to make what we may consider to be bad decisions. In the end, our job is to inform, to recommend, but patients will make the decisions that they make. And they have the right to disagree with us and to accept other risks that we would not recommend. So when we think about this whole area in a legal sense, it's the laws of negligence that apply. So it's common law. If something goes wrong, it's not criminal unless there was intent to be malicious or cause harm. It's the laws of negligence that come into play. And there are three major principles that we always need to consider. First of all, the one that where everything began legally, it's the Boland principle, which basically asks, is the treatment that you offered and carried out, does it accord with contemporary medical standards? Did you do what other doctors would do, or did you step outside of current practice? And that's a principle that's applied many areas around the world, particularly in areas that are part of the Commonwealth. Then we have the sufficiency notion. It's a notional standard of a reasonable person. Did we advise the patient of all the risks that a reasonable person would want to know? And in Australia, we have an extra layer, which is a subjective element that says, did we offer all information that the particular patient in front of us would have attributed significance to? So I'll go into that in a bit more detail. And this is important. Was the medical intervention standard practice? Did you do what other people would do, or were you an outlier? That's the first question they ask if anything goes wrong. Then they ask, would a reasonable person in the patient's position, if warned of the risk, be likely to attach significance to it? If the answer is yes, then we are under an obligation to inform the patients of that risk. Was the medical practitioner aware that the particular patient, if warned of the risk, would be likely to attach significance to it? That's tricky. It doesn't mean that the patient has to ask you a specific question. We actually have to make a judgment call ourselves as to whether would this patient in front of us be likely to attach significance to it. That's the subjective link. And that's the one I think that we find most threatening. But you know what? There's just one really easy question that I end every session with in this context. And I say, is there anything of particular concern to you that I have not addressed? And I think that that is the question that covers this difficult subjective limb. Is there anything that is of particular concern to you that I have not addressed? Please, this is your opportunity to ask. And if other stuff comes up in that regard, you can always ask me at another time. In medicine, we love looking at p-values. We consider a p-value less than 0.05 to equal proof. But in common law, proof is more likely than not. That means 51% versus 49%. As a certain Bruce Lerman discovered today, it's a very different notion than beyond reasonable doubt. And so when medicine and the law have a relationship, we don't often get on. It can be quite fraught. But we often end up in the same playpen. We need to remember that things change. What is speculative at one point in time may become established fact at another. For instance, 25 years ago, we would talk to patients about sodium valproate increasing the risk of spina bifida. It wasn't until the beginning of this century that it really became quite clear that valproate is enormously toxic, causes the valproate syndrome, high percentages of intellectual disability and autism. So it went from a medication with a few risks that patients would accept to now being a medication that we say we really advise to never use it unless absolutely essential in the context of pregnancy. So things change. What is established fact at one point in time may become speculative or disproven at another. So about 10 years ago, we would speak around the risk of persistent pulmonary hypertension in the newborn being associated with SSRIs because of research at the time. But subsequent research has shown that women with depression and anxiety are more likely to have cesarean sections, and that it's the increased risk of cesarean sections that causes the increased risk of the persistent pulmonary hypertension of the newborn, not antidepressants. Estimates of risk go up and down over time. Whereas when I was a medical student, we were told never let a patient be pregnant on lithium. Now we say lithium is one of the first choices in the treatment of bipolar depression. More about that later as well. But it's not just medical advice and the literature that evolves, local laws evolve as well. So we need to keep up to date in that arena as well. It's been the complaint of our profession that while the law has imposed quite a set of mandatory requirements upon it, it's made no attempt to inform us as to how to actually be compliant with these requirements. How can we actually achieve what they want us to achieve? And that's true. They tell us what we need to do, but they don't actually tell us how to do it. And in one sense, that's what this talk is about, is trying to bridge that gap. But it's actually just good practice. Informed consent should not be seen as an onerous compliance with minimum legal requirements, but as a means of ensuring good communication with our patients, which is positively beneficial in its own right through increasing patient understanding, managing expectations, improving compliance, and fostering a sense of empowerment and control. So in the end, everything that we do to make sure we achieve informed consent is not just good for us, it's really good for our patients. Okay, so what guidelines, I should say principles of practice for obtaining informed consent? Begin with explaining the diagnosis and what is the natural course of the illness. If we do nothing, what do we expect to happen next? Suggest treatment and speak as to whether our proposed treatment is standard practice or more speculative or more experimental or operating with a limited evidence base. Explain the proposed treatment, but also alternatives. Establish competence to agree. Ask yourself, does the patient have the mental capacity to actually consider the information we give? And are they mentally competent to actually make a decision? It's always worth involving the father if the father is actually involved with the mother. And that this is not a legal requirement, but I think just good practice. If you can get mum and dad on the same page, life's a lot easier than if you've got one parent wanting treatment and another parent actually resisting the idea of it. Detail your risk-benefit analysis and then establish patient understanding. And that's often at a later date. Actually ask your patient, what we talked about last time, what do you actually understand are the risks involved? Again, their vital question, is there anything else you may wish to know? And what are your particular concerns? Seek a decision, seek authorization, and then document it. Always document it. So what do we talk about risk? How do we disclose risk? We need to talk about the nature of risk. What is it? What is the risk? What's the magnitude of the risk? How big is it? The probability that the risk might materialize. How likely is it that this risk will actually happen? And the imminence of risk materialization. If it happens, when will it happen? That is the risk of doing something, but we also need to speak of the risk of doing nothing. So as an example, we know that Epstein's anomaly can occur with lithium use. And Epstein's anomaly involves disturbance of the right ventricle secondary to a misshaped tricuspid valve. We've known this for a long time. What is the nature of the risk? Well, it's a cardiac defect with tricuspid valve displacement. What's the magnitude of the risk? How big is it? It may require surgical correction, which is usually highly successful, but sometimes it can result in a very deformed heart and result in the patient deciding to terminate a pregnancy. It may actually not even require surgical correction at all if it's mild and the child just needs monitoring throughout life. So the magnitude can be different. What is the probability that the risk might materialize? In the general population, it's about 1 in 40,000. In patients taking lithium, it's somewhere between 1 in 1,000 and 1 in 2,000. So it's much more common than the general population, but it's still low risk. When will the risk materialize? It occurs during the first trimester exposure, and it's identifiable certainly at the 20 weeks morphology scan. And these days we do an early scan for patients on lithium at around 16 weeks to have an early look at the heart to see if this is something that we need to consider. But if a patient has a bipolar disorder, and we've got to remember lithium is still the gold standard, it's the first line treatment of bipolar disorder, the second line treatment of bipolar disorder, the third line treatment of bipolar disorder, and then we consider all the other mood stabilizers. So lithium is our best drug and with the best evidence base behind it for patients with bipolar disorder. But what if we do nothing? In the context of pregnancy, there are high rates of relapse. Medications, mood stabilizer medication cessation results in around an 85% relapse rate within pregnancy. Very, very high. Continuation of mood stabilizing medication results in about a 37% relapse rate in pregnancy. Don't often see numbers that are that different to each other. And I think there's a lot that we do in our clinics that actually reduce the risk from that 37% way further than that as well. But bipolar disorder is also associated with reduced fertility, increased risk of miscarriage, increased risk of actually getting pregnant to the wrong person, increased risks of prematurity, small for date babies, antenatal hemorrhage, particularly with mania, hypertension of pregnancy, increased risk of stillbirth. The list actually goes on. It's actually not good for babies, for mums, to actually have active bipolar disorder during pregnancy. And bipolar disorder untreated is also many comorbidities are often attached, such as smoking, alcohol, drugs, poor nutrition, domestic violence, etc., all of which increase the risks for baby as well. So we can talk about the risks of medication, but we always need to think about the risks of non-treatment. And in illnesses like schizophrenia and bipolar disorder in particular, they can be quite significant. Remember that informed consent is a process. It's not a moment in time. Always allow time for questions. Whenever possible, separate the assessment from the prescribing. Always allow your patient time to consider your opinion and your advice. And always stay open to questions again and again. Remember, patients rarely remember everything that we say. And the research has shown that patients only remember anywhere between 20 and 60% of what actually occurred in a medical consultation. Really quite surprising, but if you think of one of your own experiences of, say, seeing a medical specialist with your own lump that you think may be cancerous, don't tell me you remembered 100% of what actually occurred in that consultation. So our patients who are often mentally unwell are at a greater risk of not retaining as much as we would, and we wouldn't retain everything either. And if things go wrong, patient's memory can also be incorrect. If a woman makes a decision to expose her fetus to a risk and that risk materializes, one option for her is to say, I rolled the die and it landed on the wrong number, and I am responsible ultimately for the decision made, and my child is suffering the consequences. What a heartbreaking situation to actually be in. A better alternative is to believe that I was never told of the risk in the first place. Now, if patients don't remember everything we say, I'm not saying patients lie, but there can be a psychological defense at play that actually enacts something in which patients feel that we didn't actually disclose to them everything that we should have. So it moves the responsibility onto us. And that's why we need to be really aware, very beware of this thing called the informed consent form. It's useless. In a case of negligence, it rarely offers any protection whatsoever. All it proves is that a process occurred. It doesn't demonstrate what occurred. It doesn't say what we said to the patient. It just says to the patient says, yeah, I consent to have this, this surgery. It doesn't actually detail what we said were the risks to the anesthetic and the surgery itself. So beware of consent forms. When we treat patients in pregnancy with medications, we need to look to find the minimal effective dose. I always put the emphasis on effective. Patients and GPs do tend to have a tendency to put the emphasis on the word minimal. But beware of half treatment. A lot of patients arrive to see me on medication and unwell. If a patient's on a medication and unwell, we've got double risk exposure, risk of medication and risk of illness. Pick a risk. If you're going to treat a patient with medication, treat them effectively or don't treat them at all. Beware of, oh, you're pregnant, we'll just halve the dose and see how you go. Because all we do often is just open up the door for relapse. And if you can drop the dose so quickly when they become pregnant, why the hell didn't we do it half a year ago or a year ago? It really says that we've been over-treating someone all along. So if they're on a dose and the dose works, leave it alone. And most medications, it's not linear what crosses the placenta. It's usually a curve. That doubling the dose doesn't actually mean that we're doubling fetal exposure. It's not part of the talk today, but it's vital that lifestyle factors and psychotherapy are always part of the equation. Never treat a patient with pills alone. Always consider lifestyle factors for the particular patient, and there must always be a form of psychotherapy, as simple as supportive therapy or psychoeducation, all the way through to much more complicated therapies, say, that are trauma-focused or psychodynamic in nature, even psychoanalytic, whatever the patient prefers. Now, I mentioned guidelines before, lots of publications, but they're not that helpful in pregnancy because they all suggest avoiding first trimester exposure. But remember my previous slide, what if a patient with bipolar disorder, the average length of time it takes to relapse, 3 months. How long is the first trimester? 3 months. You want to stop the medication before they get pregnant. How long does it take to get pregnant? I don't know, anything between, 1 day and 1 year we call normal. So we've got up to 1 year and 3 months of avoiding the first trimester exposure when a patient with bipolar disorder is most likely to relapse within 3 months. So the guidelines don't help us. And the lawyers love this one. But you stepped out of the established guidelines, doctor. You need to be able to say why. Essentially, and this is vital, never offer false reassurances. In medicine, that is one of the worst things that we can do. We need to speak very openly, honestly about what we know and what we don't know. We need to educate ourselves and our patients regarding the pros and cons of both treatment and non-treatment. And we need to reveal that we cannot advise with 100% certainty. For many medications, any comfort we have when prescribing in pregnancy, the comfort comes from the absence of negative data rather than the presence of positive data. Sertraline, we've got loads of positive data. Valdoxin, we've got no positive data. All we've got is an absence of negative data for a medication that hasn't been around for that long. So I don't recommend its use in pregnancy. A risk-free scenario does not exist for any woman having a baby. There's always risk. Remember, informed consent is a process, not a moment in time. And when a patient has a mental health condition and treatment, we need to monitor them carefully, up the frequency, monitor mental state, monitor obstetric parameters, monitor the neonate. And did I mention before, document well? Did I say document well? Essentially, if you didn't write it down, it did not happen. If there is a problem, the first thing they will say to you, so what did you say to the patient in order to obtain informed consent? And this will often occur, say, 10 years after the medication exposure. And then I'll say, well, look, my normal process is to say A, B, and C. And the lawyer will say, that's your normal process, yes, doctor. But on the 1st of January 2027, did you actually follow your normal process? Well, I always follow my normal process. But did you, with this patient on this day, follow your normal process? Well, I think I did. So you think you did. Can you tell me with certainty that you did? See where we're going now? But if we write it down, that is proof that we did it. And so if any of you ever refer a patient to me, say to my preconception clinic at the Mercy, to say, you know, what do we need to think about using this medication in pregnancy? You will get a 3-4 page letter detailing everything I discussed with the patient. And at the bottom, you will see CC to patient, CC to O&G, CC to psychologist to get everyone on the same page. And if anything was to ever go wrong, for both the patient's and our sake, that document is worth gold. I'm advised that good notes equals good defense, bad notes equals bad defense, and no notes equals no defense. No notes, no defense. It all goes away really quickly. You get sued, a whole lot of money gets paid. So that's a quick solution. Bad notes, that's a lengthy process in terms of legal practice. Can go on for years and years and years of back and forth. Good notes, good defense, it gets sorted pretty quickly. I don't recommend the no notes, no defense. So make sure your notes, particularly in this area, are better than they are in other areas. Like I'm like everyone else. I can be lazy when we have one of those sessions where we talk about the same thing we talked about 10 times before, and I write same as last session. I don't write much. But if we're going to prescribe in pregnancy, make them the best notes you ever do. Write that letter, share it around, get everyone on the same page. Always establish a pathway should relapse occur. Predetermined. If you become unwell, how are you going to get help? If you write it down, send it to the patient, there can be no doubt that it was actually discussed. Because who's going to write something down and then fail to actually talk to the patient about it? A lot of this sort of talk can sound all a bit scary and a bit and lead to an avoidance of us practicing in this area. But we've got to remember, let's not forget what a privilege it is to treat patients in the perinatal setting. If we do a good job, we can work with one patient and change the outcome for many. And that's what really drew me into perinatal psychiatry. I work with a mum. I will work with a pregnant woman. And if everything goes well, it changes the outcome for the baby, her other children, for her partnership with her partner. Work with one, improve the lives of many. That's as good as it gets. Now, this is the book that we published, Megan Galbally and myself working at the Mercy together at the same time back then, about 10 years ago. Megan now runs the mental health service at the Monash Network. And Andrew Lewis, who is a professor of psychology. And we got experts from all around the world to contribute to this. There's a chapter basically on virtually every condition in psychiatry and what you need to think about in terms of treatment efficacy, risks and guidelines. If you want a copy, just go on the internet. People are selling them. They're not cheap, but it's a good reference, I think. And I look forward to questions later on. Thank you, and thank you for your time and attention. And
Thank you so much, Nathan. I think, yeah, Crystal's going to talk about health pathways. And just to say, please enter questions in the Q&A box if you have any questions that you wish us to address at the end. Thanks.
Hi, thank you, Martine. That was amazing. Good evening, everyone. My name's Crystal Barbedo. I'm the program specialist at Health Pathways Melbourne. And I understand that your time is precious and it's the end of the evening and we all want to get to the Q&A. So in the limited time we have, my goal is to demonstrate how Health Pathways Melbourne can be a fantastic resource, ensuring that you can swiftly access the right and relevant information at the point of care with your patients. Health Pathways Melbourne is a collaborative online resource developed by Eastern Melbourne and Northwestern Melbourne primary healthcare networks in partnership with healthcare professionals and organisations in the Melbourne region. Health Pathways Melbourne provides clinicians with a single website to access a comprehensive collection of locally relevant clinical information and guidelines designed to support general practitioners and other healthcare providers in delivering consistent and evidence-based care to their patients. This presentation will demonstrate how to access and navigate Health Pathways Melbourne to find relevant information relevant to tonight on informed consent and pregnancy. Okay, I'm just going to open up a navigation slide here. Okay. Here we are on the Health Pathways website. Here you can see the latest news section and along with the pathway updates that we've recently done. You can use a search bar at the top of the page by entering any relevant words. Here, we've used pregnancy medications. Alternatively, you can use a table of contents on the left-hand side. Choose the page that is relevant. Today, we are choosing medications for depression and anxiety, pregnancy and breastfeeding. As we scroll down the page, we'll come to the background section with drop-down boxes that provide additional information. As we navigate further down the page, you'll come to the assessment section. This is a concise list of steps that users may consider taking to diagnose and evaluate the severity of a patient at the point of care. Drop boxes again throughout the pathway provide supplementary information. Here we can see potential and adverse effects of medications. Further down the page, we go into the management section. This is a succinct list of steps that users may consider taking and includes additional information needed to execute these steps and links to further referral options. As discussed, we have psychotropic medications, the risks versus benefits with which Martine covered. There's also a lot of stuff in here in regards to consent, SSRIs, as we continue further down the page, we get to the referral section. This section includes locally relevant requests and referrals that a clinician may request from a third party for their patient. As you can see, shown here with a link to our perinatal psychiatry advice. By clicking on that, it will take us out to the referral page. And here we have a page that set up referrals. We have severe perinatal, private hospitals, public hospitals with drop-down boxes specific to the East and Northwest catchments. Returning back to the page, we have the information section at the bottom. Here you'll find information for healthcare professionals and for patients. This slide provides a list of relevant and related pathways for tonight's topics, including medicines, information and resources, legal ethical, with consent being our major one there, antenatal care and obstetric referrals. To access Health Pathways, just go to the website and type in the address Melbourne.healthpathways.org.au. Health Pathways is available to general practice teams and other clinicians in the Eastern Melbourne PHN and Northwestern Melbourne PHN catchments. If you don't have access yet, you can click on the register button, which brings up an online form. We use the QR code there. Alternatively, just send us an email through at info@healthpathwaysmelbourne.org.au. Thank you very much for your time.
Thanks. I can't see any questions in the Q&A. But Martin, I've got a question just about the preconception clinic and referral. What would be a good or a type of referral that you'd like to see, or what would you like our primary care colleagues to know about this particular clinic?
Yeah, so look, basically we've established a clinic, which is a statewide service in which, any patient who has a mental health condition that's on treatment can be referred for advice regarding, what are the safety, can you please just present a risk-benefit analysis for this particular patient? And then I will go through it. For instance, the journal articles talk about SSRIs, or they talk about antidepressants. Well, we know sertraline is number one. Lexapro and Cipramil are number two. Fluoxetine comes in later. Paroxetine is lower down. Valdoxin shouldn't be on the list because we know nothing. So we can't just talk about antidepressants. Where, if you're looking for specific advice around a particular medication, feel free to use our service at the Mercy. At the same time, please don't think that there's any diagnostic assessment is going to occur. I will address I will assist you with the informed consent process, but I will not be doing my own 291 full assessment of the patient in order to offer you an opinion regarding the accuracy of the diagnosis. That's for another time and another place. I believe that the Royal Women's Hospital are in the process of setting up such a clinic as well, and that's great. At the moment we're statewide. I've seen, people in Swan Hill and given GPs advice around, olanzapine in pregnancy, for instance. So if we can be useful, the letters we write for you is that it's done in a way you send one patient, you're then informed about everything you need to know, and then you can use that as a template for the next 10 patients on that medication that come to you. So, don't use it as, every single patient on a medication sent to the Mercy. Use it as a way for me to help you know what you need to talk with patients, and then you'll become experts in it and feel much more comfortable in having that conversation yourself. Yeah, so it's not a service for everyone every time, but it's a way that we can get the current information out there so that, we enhance the chances of patients and babies having the best outcome.
Yeah, that's great. Thank you, Martin. And I do have one question here that I can read out just for everyone to see, or I can click the answer live as well. So someone asked, would you change someone from a stable dose of another SSRI, for example, fluoxetine, escitalopram, to sertraline because it's the safest?
Look, usually I don't, because if a patient's on fluoxetine and it's working, we know that fluoxetine works for this patient. It's a nice idea. Swap them over to Zoloft. Well, Zoloft may or may not work. So we go through a process of weaning off one medication, establishing a therapeutic dose for another medication. So we're talking months here. Patients turn up wanting to be pregnant tonight. They don't turn up wanting to be pregnant in a year. Patients turn up already pregnant. And do we want to put a fetus and a patient through withdrawal and the onset side effects of a new medication for one that may or may not work? And when we look at the literature around the effectiveness of our treatments, we get a little bit depressed because our treatments are not as good as we think they are. There's a lot of patients who actually don't benefit from current pharmacological treatments in their simplest forms, and more we're getting complicated in terms of using, polypharmacy to get people right. And so if in the past I used to suggest, let's swap to Zoloft, I don't do it anymore because I think if it's working, the old thing, everyone knows, if it's not broken, don't fix it. If they are on, Valdoxin, for instance, I would then be saying, look, we know I can't give you any advice in pregnancy about this medication at all. That seems to be the only antidepressant you've ever been on. Let's think about using an alternative that's safer in the pregnancy context and lactation context.
That's great. Martin, there are two more questions that's just come through.
Yep.
So I think the first one is specifically also about the preconception clinic. So does that mean you can speak to patients who who have drug and alcohol dependence, but also is on ADHD medication?
I will speak to them about the risks of their ADHD medication. In terms of the drug and alcohol, that's not for me. In that clinic, Yeah. So if a patient is on dexamphetamine and you'd like to know about what do we need to think about in terms of risks for mother and child, I'll have that conversation and I'll say, you'll need to have your drug and alcohol problems addressed elsewhere because both of those are detrimental to both you and your unborn. But I won't. I've got 4 spots on a Monday. So I don't have the availability to treat everything. Yeah.
Yeah, that's fair. And also, Martin, just an aside, have you seen an increase in, I guess, women on stimulant in the peripartum periods in the previous 12 to 24 months?
It has absolutely skyrocketed.
Yeah, same.
Yeah, and look, we're stepping back and looking at the whole OxyContin pandemic. And I think in 20 years, we'll be looking back at this era saying, what the hell happened in terms of the ADHD pandemic? And that is not saying ADHD doesn't exist. It's not saying that there are people who suffer enormously and benefit enormously from treatment. But there's no way that the percentage of the population that are being treated for ADHD have ADHD. And the problem is, if I went home and took a bit of dexamphetamine tonight, I'd have a good night and probably be really on tomorrow at the office. And then I would feel focused. I would feel my mood's improved. I'd feel good. So that doesn't mean I've got ADHD. It just means I like a bit of speed. And that's the problem with ADHD treatment is a lot of people feel better for it. But what I've seen a lot of in my private practice is patients turning up a complete mess because they have an underlying anxiety disorder. Guess what? Anxiety disorder leads to forgetfulness, crowding of thought, not being able to stay on task, blah, 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 blah. If you're wearing the goggles that look for ADHD, you find it with anxiety disordered patients. They get put on methylphenidate or dexamphetamine, and then the anxiety explodes. And they turn up here a mess. I met a woman a few weeks ago where it actually triggered a serotonin syndrome, combination of their SSRI and dexamphetamine, and they ended up quite sick in hospital. So tread with caution in this space. I'm not an ADHD expert in any way. I know what we need to think about in terms of using those medications in pregnancy and lactation, but I think we have medicalized normality to the point where a lot of our population now seek diagnosis. When I started in psychiatry, everyone resisted diagnosis. It was a matter of like, don't you dare say I've got this disorder. No, it's a variation of normal. And there was a real anti-psychiatry movement in which the population would resist getting a label. Now we've got a population that hunts down labels because in their own minds it explains their lives to them. And then it becomes part of identity.
Yeah, I was thinking exact same. Yeah.
And once it's part of identity, it then becomes the excuse for not developing as a human being because I have a disorder, therefore I'm restricted. And so I think our diagnosis and treatment, when we get it wrong, actually steal people's lives away from them. So think hard, tread cautiously in the ADHD area is my advice.
I agree with that 100%. And also certainly in the SAGE clinic at Mercy for Women, which is the clinic looking after women with substance use disorder. Previously, we were known as the transitions clinic. We're seeing a lot more patients who are on ADHD, a stimulant medication during pregnancy, who also have substance use disorder as well. Again, it's about really optimizing the treatment of dual diagnosis and making sure that they address the underlying substance use disorder as well. Yeah. Preferably before pregnancy, but of course during pregnancy refer early to specialist clinics as well. Martin, would you have one last question? Is it okay if we address that before we close it off? Yeah, just very quickly. So someone asked, thoughts on low-dose Seroquel and continuing it during pregnancy and breastfeeding if using this for sleep?
So when we go through the list of the things that we think about, to date there's been no association between quetiapine and any increased risk of birth defect, regardless of the dose. In terms of pregnancy itself, Seroquel has been linked to an increased risk of gestational diabetes, but the research that we've done together with Megan, combining our data at the Mercy with the data of her old hospital in Western Australia, said that that risk appears to kick in at around the 300 milligram mark. Babies exposed to Seroquel tend to be larger. Whether that's dose dependent or not, probably is. But if patients on Seroquel, I would recommend growth monitoring in the 3rd trimester. Seroquel is a sedative, so baby may be born, floppy and tired. It's a medication, so therefore there may be some withdrawal symptoms that we need to monitor for. In terms of long-term data, we don't have any data to say that these medications, particularly in low dose, have any negative long-term implications. At higher doses, there may be delays in motor skill development, but whether that's an illness factor or a medication factor, we don't know yet. Quetiapine comes through in very small quantities in breast milk, so can be considered to be safe in breastfeeding. The relative infant dose really is very low, but always advise the mother to not co-sleep with baby if she's on Seroquel, and to avoid being dopey and breastfeeding or feeding baby on a couch whilst under the influence of Seroquel.
Yeah, that's great. There was one question that came through, Martin, just lucky last. Just wanting to know about SSRI during pregnancy and what does neonatal withdrawal syndrome look like? So the neonatal adaptation syndrome.
Yeah, so problems with neonatal adaptation basically means that baby can be a bit irritable, bit narky, bit difficult to feed, bit unsettled. Well, that's sort of a lot of babies. The dead giveaway is that they can have muscle jerks, where they just, jerk. But if you look at their faces, they don't seem to grimace. So it doesn't actually seem to cause them much distress. It causes much more distress to the parent who sees their child having muscle jerks. And you think a fetus has basically lived in a crush chamber for 9 months. I don't think a few jerks is going to upset them too much. It tends to be transient, lasts a week or so and goes away. And that's where the SSRIs are different. I've never, ever seen it with Zoloft, regardless of dose. Zoloft is a very large molecule that is very highly protein bound, so the placental passage is minimal. Paroxetine is a very small molecule with very limited plasma binding, so it has very high rates of withdrawal symptoms. Lexapro occasionally, Cipramil occasionally, fluoxetine reasonably common. The SNRIs pretty common. Effexor, your baby will have withdrawal symptoms. We'll just have to accept that. It can also be associated with seizures, rarely. Temperature regulation disturbance, rarely. And so I say, if the medication's not Zoloft, I say at the hospital, just get a pediatrician to pop in each day and to say hello and have a quick look. You know, by far the majority of babies don't end up in special care nursery, which is different to medications like, you know, lithium or the antipsychotic medications, where significant numbers of babies end up in special care nursery, and that's both because of the illness itself, but also the treatments.
Yeah, that's great. Thank you so much, Martin. I think that's all the questions we have. We probably went a bit over time, but I think it's great to have questions. And just a reminder for everyone to please use the feedback link at the end, just so that we know whether it's been helpful and how to conduct the next talk. So thank you again, Martin. I think that's it.
Thanks for having me. Hopefully it was useful.
Thank you.
To all the attendees, have a great night, and hope you got something out of today. Cheers.
Really helpful. Thank you.
Ciao.
Thanks, everyone. Bye.